It's often said that cow's milk protein allergy, or CMPA, affects maybe around 2% of young kids.
Hmm.
But here's something interesting. Some data hints that number might have actually gone up in recent decades.
Yeah, that's a point of discussion.
Okay, so let's really dig into this. It's a common allergy, affects a lot of infants and toddlers.
Yep.
This deep dive is all about CMPA.
Exactly. Cow's milk protein allergy is definitely a key topic in early childhood health.
Mm,
So today, we're going to explore what CMPA really is,
right.
different ways it shows up, because it's not just one thing how doctors diagnose it, the sort of natural course it takes,
Uh-huh.
and what treatments are available now, including, the newer approaches like oral immunotherapy.
And we've looked through a fair bit of material for this, scientific articles, clinical reviews,
Junk stuff.
to try and pull out the most important, most insightful bits for you. Our aim is really to give you a clear, solid understanding of CMPA.
Cut through some of the noise, maybe.
Yeah, exactly. And hopefully highlight some surprising facts and key takeaways, especially if you're interested in children's health, allergies, that sort of thing.
Sounds good.
Okay, so let's start right at the beginning. What exactly are we talking about when we say CMPA?
Okay, so fundamentally, CMPA is when the body has a reproducible adverse reaction. Basically, a bad reaction that happens predictably
Okay.
to one or more proteins found in cow's milk. Usually it's proteins like casein or beta-lactoglobulin.
And what makes it different from, say, lactose intolerance? People sometimes mix those up, don't they?
They do, and the key difference is the immune system. CMPA involves an immunological mechanism.
Ah,
Lactose intolerance, on the other hand, that's a digestive issue. Trouble breaking down the milk sugar, lactose. CMPA is the immune system reacting wrongly to the milk protein.
got it. So the immune system is the trigger. How does that actually play out? You mentioned different ways it shows up.
Yes, exactly. We tend to categorize CMPA based on how the immune system reacts. There are, broadly speaking, three main types. First, you have IgE-mediated CMPA. This involves IgE antibodies, which are sort of the classic allergy antibodies.
Right, the ones most people think of with allergies.
Pretty much.
Yeah.
These reactions are typically fast. They happen within minutes, maybe up to 2 hours after having milk.
And the symptoms?
They can affect various parts of the body. Skin reactions like hives, itching
Mm-hmm.
in the mouth or throat, maybe swelling. Respiratory issues like coughing, wheezing. Gut symptoms, vomiting, diarrhea. And in severe cases, it can affect the cardiovascular system.
Leading to anaphylaxis.
Yes, potentially leading to anaphylaxis, which is the most severe, life-threatening reaction.
Okay, that sounds really concerning. What are the other types?
The second type is non-IgE-mediated CMPA.
Mm.
Here, the reaction doesn't primarily involve those IgE antibodies.
And these are slower?
Much slower, yeah. The reactions are delayed. We're talking maybe 48 hours, sometimes even days after consuming cow's milk.
Wow, days later. That must make it harder to pinpoint.
It really does. And the immune mechanisms aren't as clearly understood. Plus, we don't have simple blood tests, specific biomarkers to identify them easily.
What kind of conditions fall under this non-IgE type?
Well, examples include things like cow's milk enteropathy, which affects the gut lining,
Okay.
food protein-induced proctitis, or proctocolitis, often seen as blood in the stool in babies who otherwise seem well.
Right, I've heard of that.
FPIES, which stands for food protein-induced enterocolitis syndrome, known for severe vomiting and diarrhea,
Okay.
and a rarer one called Heiner syndrome, which affects the lungs.
And there was a third category you mentioned.
Yes, the third is what we call mixed CMPA. As the name suggests, it seems to involve both IgE and non-IgE mechanisms.
So a bit of both worlds.
Kind of. People with mixed forms might have immediate symptoms, delayed symptoms, or more chronic ongoing issues.
Like what?
Things like atopic dermatitis eczema can sometimes have a mixed CMPA component. Allergic eosinophilic esophagitis, or EOE, and eosinophilic gastritis are other examples often put in this mixed category.
Gosh, it really does seem to show up in so many different ways. That must make figuring out how common it actually is quite a challenge.
Absolutely. It's fascinating, actually. Before the 1950s, CMPA wasn't really diagnosed much.
Really?
Yeah. But since the 70s, the estimates of how often it occurs, well, they vary wildly. Some studies suggest around 1.8%. Others go as high as 7.5%.
Wow, that's a huge range. What, such a big difference.
It really comes down to how CMPA is defined in the study, the diagnostic criteria used, and the study design itself.
So that headline figure, the sort of around 2% number we started with, it's really just a rough average, isn't it?
It is, and it masks a lot of that variation. Depending on how you count, like you said, it can seem much higher or lower.
So it's not just counting cases, but how you count them that matters.
Exactly. How prevalence is reported varies a lot between studies, different designs, different methods, different definitions of CMPA, and maybe even real differences between the populations being studied. Plus, as we touched on, sometimes non-allergic things like lactose intolerance get mistaken for CMPA, muddying the waters.
That makes sense. So how have researchers tried to get a more reliable picture?
Well, meta-analyses are really helpful here. These studies combine the results of lots of individual studies.
Okay.
For example, one big meta-analysis by Roney and colleagues looked at studies from the 90s up to 2005. They found a massive gap between how many people said they had a food allergy versus how many had it confirmed with objective tests.
How big a gap?
Huge. Self-reported CMPA ranged from 1.2% to 17% in different studies.
17%.
Yeah. But when they looked at studies using skin tests or blood tests alone, the numbers were lower. And studies using oral food challenges, which are more definitive, showed prevalence from 0% up to maybe 3%.
Wow. So relying on self-reporting really inflates the numbers, doesn't it?
It certainly seems to.
Yeah.
Another major meta-analysis, this one focusing on Europe by Nauru and colleagues, looked at data from 2000 to 2012. They found the same pattern. Self-reported rates were higher than objectively diagnosed rates. Their estimate for CMPA confirmed by oral food challenge was around 0.6%.
Okay, so that's closer to maybe 1% or even less when it's properly confirmed.
That seems to be the direction the more rigorous studies point. These analyses really show how things like geography, who you're studying, general population versus allergy clinic patients, their age, study size, and the limits of the tests all affect the numbers we see.
What about more recent large studies that follow kids over time? Any insights from those?
Yes, the Europreval birth cohort study was a big one, published around 2015. They followed over 9,000 kids across 9 European countries up to age 2.
And what did they find?
Overall, the incidence of challenge-driven CMPA was just 0.54%.
0.54%, so even lower.
Yeah. But interestingly, they saw big differences between countries. It was higher, around 1%, in the Netherlands and the UK, but less than 0.3% in places like Lithuania, Germany, and Greece.
Fascinating variation.
And another really key finding from Europreval was about outgrowing it. Babies who had CMPA without those specific IgE antibodies were very likely to tolerate milk within a year.
Oh, really?
Yeah, compared to only about half of the kids who did have the IgE antibodies. So whether that IgE is involved seems to matter a lot for prognosis.
That's a crucial point. So these more rigorous studies suggest the actual rate of confirmed CMPA might be lower than some older, perhaps broader estimates.
That seems to be the trend, yes.
Yeah.
If you look at childhood overall, that 2% figure for kids under 4 is often quoted.
Right.
But confirmed rates in adults are much, much lower. Maybe 0.1% to 0.3%.
And is adult CMPA always something left over from childhood?
Mostly, yes. But there is some evidence suggesting adults can develop CMPA for the first time, maybe more often in women, according to some reports, though it's less common.
Okay. But even if the overall prevalence isn't sky high, cow's milk is still a major player in serious allergic reactions in kids, right?
Absolutely.
Yeah.
It remains a very significant trigger for food-induced anaphylaxis in children. You definitely can't underestimate its impact.
Okay, so we're getting a better handle on what CMPA is and maybe roughly how common it is. Let's shift to diagnosis. How do doctors actually figure out if a child has it?
Right. Diagnosis, getting it right early on is so important. It guides the dietary management and helps avoid putting kids on unnecessarily strict diets, which can impact growth and nutrition, especially when they're so young.
Makes sense. So what's the process?
It usually starts with a really thorough clinical history. What were the symptoms? Exactly when did they happen in relation to having milk?
Yeah.
How severe were they?
Okay.
And also, is there a personal or family history of allergies, eczema, asthma, that sort of thing, and then a physical examination?
And after the history and exam, allergy tests, like skin pricks or blood tests.
Exactly. Skin prick tests, SPTs, and blood tests for specific IgE antibodies to cow's milk proteins are common tools.
Right.
But, and this is really crucial, these tests on their own can't always distinguish between just being sensitized to milk.
Meaning the body has made the antibodies.
Yes, meaning the IgE is there, but it doesn't necessarily cause a reaction, versus having a true clinical allergy where you actually get symptoms when exposed.
Ah, Okay, so a positive test isn't the end of the story.
Not at all. It's a piece of the puzzle. A history of symptoms after milk exposure, combined with that positive test result, makes the diagnosis much more likely. The history is key.
So if the tests are positive, but the history isn't clear, or maybe the tests are negative, but you still suspect it, what then?
That's where the oral food challenge, or OFC, comes in. When it's needed, the OFC is really considered the gold standard, the most reliable way to diagnose CMPA.
The gold standard. How does that work?
Well, the most rigorous type is the double-blind, placebo-controlled food challenge, DBPCFC.
That's a mouthful.
It is. Basically, neither the patient nor the clinician knows if they're getting the real milk protein or a placebo, like a dummy substance. That removes any bias. But honestly, in regular clinical practice, a full DBPCFC isn't always done or necessary. Sometimes, an open challenge where everyone knows what's being given is enough if the situation is clear.
And how is the challenge actually done? Just give them a glass of milk?
Oh no, definitely not. It's
That's
done
so
very carefully under strict medical supervision.
Right.
You start with a tiny amount of the milk protein and gradually give increasing doses over several hours, watching very closely for any reaction.
Okay.
Sometimes, especially if you're not expecting a strong reaction, they might start the challenge using baked milk.
Baked milk. Why baked?
Because the high heat changes the milk proteins, makes them less allergenic for many people.
Ah, interesting.
So if someone reacts to regular milk, but might tolerate baked milk, or if the suspicion of allergy isn't super high, starting with baked milk can be a safer first step.
Yeah.
Any reaction is likely to be milder.
That makes sense. Safety first.
Always.
Hmm.
These challenges must be done in a clinic or hospital equipped to handle severe reactions, especially if the child has had positive tests or a history of immediate reactions.
Absolutely. Going back to the skin and blood tests, are there any specific levels, like a certain IgE number or skin test size, that strongly point towards an allergy?
Researchers are always looking for predictive markers, and yes, there are some thresholds that have been studied. For example, in kids under 2, a specific IgE level to cow's milk above 5 kcal,
Yeah.
or a skin prick test wheel size above a certain diameter, like 6 or 8 millimeters, depending on the exact test used.
Yeah.
Those suggest a higher probability of having a true clinical allergy.
Yeah.
But there's no single magic number that definitively diagnoses CMPA for everyone.
So they're useful guides, but not absolute proof.
Exactly. They add weight to the evidence, but you still need to consider the whole picture, especially the clinical history.
Right.
And it's also worth remembering that these IgE tests, both skin and blood, are actually very good at predicting when an immediate reaction is unlikely. Their negative predictive value is excellent.
Meaning if the test is negative?
If the IgE tests are negative, it's highly unlikely the child will have a rapid IgE-mediated reaction. However, if the history strongly suggests a delayed non-IgE reaction, a negative IgE test doesn't rule that out.
Okay.
So even with negative IgE tests, if there's a strong suspicion based on symptoms, an oral food challenge might still be necessary to be absolutely sure or to diagnose a non-IgE type.
Got it. So it's this combination of careful history taking, using the tests as guides, and potentially the oral food challenge to nail the diagnosis.
Precisely.
Okay. Now, what about why some kids develop CMPA? Are there things that make it more likely? What are the risk factors?
Yeah, that's a huge area of research. There are definitely factors that seem to increase the risk. Some we can't change, non-modifiable factors.
Like genetics?
Genetics plays a role. Having a strong family history of atopy allergies, asthma, eczema is a big risk factor.
Okay. Also, being male seems to slightly increase risk in childhood. And some studies suggest differences based on race or ethnicity, with higher rates reported in Asian and Black children compared to white children in some populations.
Interesting. Anything else non-modifiable?
Well, one study, perhaps surprisingly, found a higher rate of CMTA in babies whose mothers had a university-level education. The reasons for that aren't clear.
Huh. That is unexpected.
And having atopic dermatitis, eczema, especially if it starts early in infancy and is moderate to severe, is a known risk factor, particularly for the IgE-mediated type of CMPA.
That link between skin and food allergy keeps coming up.
It does. Also, there's some interesting data around parents' country of origin. Kids born in the U.S., for example, seem to have a higher risk of food sensitization than kids who immigrate, especially if they arrive later in childhood.
Why might that be? Environmental factors?
Possibly. Differences in environment, diet, maybe the microbiome, the gut bacteria. It's complex.
Okay, so those are things mostly out of our control. What about factors we might be able to influence? Modifiable risks. Yes, there's a lot of focus on those. Things like the hygiene hypothesis, the idea that our cleaner environments might play a role.
Right.
the gut microbiome composition, dietary fats like omega-3s, antioxidant intake, maybe use of antacid medications early in life, obesity,
Hmm.
and a really big one, the timing of when allergenic foods are introduced into the diet.
Ah, yes, the introduction timing debate.
Exactly. And related to that is the dual allergen exposure hypothesis.
Explain that one.
The idea is that exposure to food allergens through inflamed or broken skin, like with eczema, might promote sensitization, developing the allergy,
Okay.
whereas early and regular exposure through the mouth, eating the food, might promote tolerance. So
Yeah.
skin exposure bad, oral exposure good, potentially.
Fascinating theory. What about things around birth, like C-sections or prematurity?
Premature birth does seem to be linked with a higher risk of CMPA, maybe because the gut barrier is more permeable, less mature. But the mode of delivery C-section versus vaginal birth, the evidence for a consistent link to CMPA risk is actually pretty weak or conflicting.
Right. And vitamin D, we hear so much about its immune role.
Vitamin D is complicated. Some studies link low vitamin D levels to higher allergy risk,
Mhm.
but others have found associations with higher levels too, or no link at all. So the jury's still out on vitamin D's exact role in CMPA. More research needed there.
Definitely sounds like it. What about breastfeeding? That's usually protective, right?
Absolutely. Breastfeeding is hugely important. It helps establish the baby's gut microbiome,
Yeah.
provides ideal nutrition, supports immune system development. So many benefits.
Hmm.
Human milk contains lots of immune modulating components. And importantly, current guidelines strongly recommend continuing breastfeeding, even if an infant has CMPA. The mother might need to modify her diet, but breastfeeding itself is encouraged.
Good to know.
And there's also evidence suggesting that continuing to breastfeed while introducing solid foods, maybe around 17 weeks or so, is associated with fewer food allergies later on.
Interesting. But what about introducing cow's milk itself early, like through formula? Is that protective or a risk?
That's another area with conflicting data, honestly.
Hmm.
Some studies have suggested early formula exposure might increase risk, while others, particularly more recent ones looking at early regular introduction, hint it might actually be protective against developing CMPA.
So, still evolving.
Very much so. It's an active area of research, trying to figure out the optimal timing and way to introduce potential allergens.
Okay, this gives us a good sense of the risk factors. Now, once a child is diagnosed, what usually happens? What's the natural history, the prognosis? Do most kids outgrow it?
That's the hopeful part for many families. The good news is that, yes, many childhood food allergies do resolve over time.
Ew.
And milk allergy generally has a relatively high rate of resolution compared to some others, like peanut allergy.
Okay. What kind of rates are we talking about?
Studies vary, but broadly, figures often suggest that maybe over 50%, perhaps up to 75%, or even 80%, some older studies, will outgrow their CMPA by school age, say 5 to 10 years old.
That's pretty encouraging.
It is, however, there's always a however.
Uh-oh.
The findings aren't totally consistent across all studies. Differences in study design, who they followed, how long they followed them for, it all plays a role.
Right.
And some more recent research seems to suggest maybe slightly less optimistic resolution rates, or perhaps that it's taking longer for kids to outgrow it than we used to think.
So not a guarantee, and the timeline can vary.
Exactly. And it also depends on the type of CMPA.
Ah, back to the IgE versus non-IgE distinction.
Yes. Generally, non-Ig-mediated allergies tend to resolve more quickly than the Ig-mediated ones.
Okay. Are there any clues early on that might suggest if a child's CMPA is likely to stick around for longer? Factors associated with persistence?
Yes. Researchers have identified several factors, things like having more severe symptoms initially,
Makes sense.
being diagnosed at a very young age, having other allergic conditions like asthma, eczema, or other food allergies, especially egg allergy,
Yes.
reacting to a very small amount of milk protein, meaning a low threshold dose,
Mm-hmm.
and interestingly, reacting to baked milk when they're first exposed to it.
Mm-hmm.
That seems to be a marker for more persistent allergy.
So tolerance to baked milk is a good sign.
It often is, yes.
Yeah.
Being able to tolerate baked milk is generally seen as a positive prognostic factor.
Mm.
It suggests a higher likelihood of eventually tolerating unheated milk, too.
And might even help speed things up.
There's some thought that incorporating baked milk into the diet, if tolerated, might actually help accelerate the development of tolerance to regular milk. It's
Yeah.
like a stepping stone.
Fascinating. What about tracking those IgE levels or skin tests over time? Do they tell us anything about prognosis?
They can. Generally, Persistently high specific IgE levels or large skin prick test reactions over time are associated with a lower chance of outgrowing the allergy quickly. Conversely, if you see those IgE levels or wheal sizes decreasing year after year, that's usually a good sign, suggesting tolerance might be developing.
So regular monitoring can be helpful.
It can give clues, yes, but again, no absolute certainty from the tests alone.
Understood. So knowing all this about the natural history, how does it influence treatment? Traditionally, it was just strict avoidance, right?
That's right. For a long time, the cornerstone of CMPA management was strict dietary elimination, avoiding all cow's milk protein in any form.
Which sounds really difficult.
It is. It impacts shopping, eating out, school, social events, and even with careful avoidance, accidental exposures happen.
Yeah.
That leads to anxiety, fear of reactions, and can significantly impact the quality of life for the child and the whole family.
I can imagine. So are there alternatives now? You mentioned oral immunotherapy earlier.
Yes, OIT oral immunotherapy has really emerged as a promising, though still evolving, treatment strategy for persistent food allergies, including CMPA.
Okay, OIT, we hear more about that now. How does it actually work for milk allergy?
The basic principle is to give the person tiny, carefully controlled, and gradually increasing doses of the allergen, in this case, cow's milk protein over time.
To try and, what, retrain the immune system?
Essentially, yes. The goal is to induce desensitization. That means raising the threshold amount of milk the person can tolerate without reacting.
Okay, so they become less sensitive.
Exactly. And the ultimate hope for some is to achieve tolerance, which means they can eat milk freely even after stopping the OIT therapy without reacting. That's the ideal. But often the main goal is desensitization for safety and quality of life.
So maybe not cure it completely, but make accidental exposures less dangerous.
Precisely. Protecting against severe reactions from accidental ingestion is a major aim, allowing for a less restricted diet and reducing anxiety.
Who is OIT typically for? Is it for every child with CMPA?
No, not typically. It's generally considered for children with persistent Ig-mediated CMPA.
The faster reacting type.
Yes. Usually in kids where strict avoidance is proving very difficult or significantly impacting quality of life, and who haven't outgrown the allergy naturally, often it's considered around age 4 or 5 as tolerance might be more achievable before school starts.
What's happening immunologically during OIT? What changes in the body?
We see shifts in the immune response. Typically, the IgE antibody levels, those allergy antibodies, tend to decrease over time. While another type of antibody, IgG4, often increases. IgG4 might act as a blocking antibody, interfering with the allergic reaction.
Interesting.
There's also evidence for changes in immune cells, like a reduction in the activity of Th2 cells, which drive allergic inflammation, and the cytokines they produce.
So real changes at the immune level. What does the process actually involve for the patient and family?
It's usually done in two main phases. First is the induction, or dose escalation phase.
Starting low and going slow.
Very low and very slow initially. You start with minuscule doses, often given in a supervised setting, and gradually increase the amount over weeks or months following a specific protocol. The starting dose is really important and personalized based on risk.
Right.
Once they reach the target maintenance dose, they enter the maintenance phase. This involves consuming that specific amount of milk protein regularly, usually daily, at home.
And they have to keep doing that.
Generally, yes, to maintain the desensitization. We're still learning about the long-term effects and how durable the tolerance is if OIT is stopped. That's an area of ongoing study.
Okay. How successful has milk OIT been in studies? Does it work?
The results vary quite a bit between studies, depending on the protocol used, the type of milk product like liquid milk versus milk powder, and the population studied. But many studies have shown pretty good rates of achieving desensitization, allowing kids to tolerate a significant amount of milk. Some also report achieving full tolerance in proportion of patients.
Have there been studies comparing it directly to just avoidance?
Yes. Randomized controlled trials have compared OIT to the standard elimination diet. Some of these have found OIT to be superior in increasing the amount of milk tolerated and reducing severe reactions to accidental exposures.
Okay.
One study, for example, showed a higher rate of achieving unresponsiveness, basically being able to eat milk without reacting in the OI2 group compared to the avoidance group after 6 months. So it can be effective.
That sounds really promising. But what about the downsides? Are there risks or side effects?
Yes, that's a really important consideration. OIT is not without risks. Side effects are actually quite common, reported in maybe 50–60% or even more participants in some studies.
What kind of side effects?
Often they're mild and localized things like itching in the mouth or throat, maybe some mild stomach upset, or runny nose and itchy eyes.
Okay. Manageable stuff.
Often, yes.
Yeah.
But more significant symptoms can occur, like white hives, wheezing, vomiting, or severe abdominal pain. These can sometimes lead to needing to stop the therapy.
And the risk of severe reactions like anaphylaxis?
Yes, anaphylactic reactions requiring epinephrine have been reported during OIT, although thankfully they seem to be less frequent than the milder side effects. Factors like illness, exercise soon after a dose, or maybe seasonal allergies can increase the risk of reactions during OIT.
So it absolutely needs close medical supervision.
Constant medical supervision by specialists experienced in OIT is essential. It's definitely not something to be tried at home or without expert guidance.
Understood. And what about the impact on quality of life? Does going through OIT with the appointments and potential reactions actually help families overall?
That's a key question. Several studies have looked at this, and generally, while OIT involves a significant commitment and potential stress during the process,
Right.
many families report improvements in quality of life after successfully completing the escalation phase or achieving desensitization.
Because they worry less.
Exactly. Less fear of accidental reactions, more dietary freedom for the child. It can make a big difference. But the journey itself can be demanding.
Okay. This has been incredibly informative, covering so much ground on CMPA. If we were to boil it down, what are the absolute key takeaways for our listeners?
I'd say first remember CMPA is common in babies and young kids, and it can look very different immediate IgE reactions or delayed non-IgE ones.
Right. Not just one thing.
Second, diagnosis is a process. It relies on a good history, uses tests like IgE or skin pricks as clues, but the oral food challenge is often needed for confirmation.
Mhm.
Don't rely on tests alone.
History and challenge are key.
Third, many kids do outgrow CMPA, especially the non-IgE types, but persistence is possible. Factors like severity, other allergies, and baked milk tolerance give clues to the prognosis.
Okay.
And finally, treatment is evolving. Strict avoidance is the baseline, but OIT is an emerging option for persistent IgE-mediated CMPA, aiming for desensitization or tolerance, but it requires careful medical management due to side effect risks.
And underlying all of that.
Early, accurate diagnosis is crucial to guide everything that follows.
Excellent summary. And maybe a final thought for everyone listening. Given that food allergies like CMPA seem to be, if not increasing, certainly a major ongoing health issue, and our understanding and treatments like OIT are advancing so rapidly, what do you think are the biggest challenges, but also the biggest opportunities looking ahead? How do we best support the well-being and quality of life for these kids and their families in the future?
That's a great question to ponder. Balancing the potential of new therapies with safety, ensuring access, managing the psychosocial impact, lots to consider.
Definitely something to think about and maybe explore further.
Absolutely. Keep learning, keep asking questions.
Thanks so much for sharing all this insight today, and thank you for joining us for this deep dive.